Okay. Um, well, I think we're up and running. It's now time to begin the session. Hi, everybody. My name's Kieran Agarwal Harding. I'm the director of the Harvard Global Orthopedics Collaborative. And thank you, everybody, for joining us today for our first live session on in our series of complex lower extremity trauma. This is now our third year running this conference. We're very grateful for, no, I'm sorry, it's our fourth year running this conference. And we're really grateful to everybody for the continued interest in these virtual conferences. So this conference series will involve 3 weeks, as many of you know already. The first week today will be on pelvic fractures. Next week we'll do acetabulum fractures, and then the week after will be on femoral neck fractures. Haley, next slide, please. For those who haven't had a chance yet, please do fill out our pre-conference survey as well. Haley, you able to go to the next slide? Haley, are we struggling with your internet connection? Teja, do you mind sharing the slides?
Yeah, let me pull them up.
Thank you. Thank you, everybody. Just sit tight for us. A little bit of a technical glitch. We'll be right back. Oh, there we go. All right. So, oh, thank you, Teja. Let's get those up in presentation mode. Great. Okay. All right. Back to it. So thank you, everybody, for joining our session today. Teja, can you go back, please? So this is our course agenda for the 3 sessions. Today we'll be talking about pelvic fractures. Next slide, please. So just, we're all very familiar with Zoom because of the pandemic, but just as a reminder, we have the ability today for everybody to have closed captions with live translation, so translated subtitles. So at the bottom of your screen, you'll see a little button that says Show Captions. If you click on that, it should pull up the caption window, and you should be able to show your translated subtitles. To engage in the conversation, please feel free to use the raise hand function so we can call on you and you can unmute and share your comment or your question. We also have the chat feature there in the Q&A, and many of us will be moderating that to get you guys involved in the conversation. Next slide, please. So as I mentioned, the course objective today is really, first of all, to improve participants' knowledge of complex lower extremity trauma management principles. The second course objective is to foster this international discussion regarding orthopedic trauma care delivery, specifically in limited resource settings. This is really the purpose of our conference series and all of the conferences we run. Third objective is to motivate and support the younger generation of orthopedic surgeons practicing in low and middle income countries. So we really want to have this as a conversation, a dialogue, very informal. So please, all those who are listening today, please feel free to ask your questions. And this is an opportunity for all of us to learn together. Next slide. As I mentioned, I'm Kieran Agarwal Harding. I'm leading the course organization, and I'm the director of the Harvard Global Orthopedics Collaborative. Next slide. And here I will hand it over to my 2 wonderful colleagues, Dr. Shravya Challa and Dr. Haley Daniel, who are the chief residents at the Harvard Combined Orthopedic Residency Program in Boston. Both are going into trauma and are very interested in pelvic and acetabular fractures. So I'll let them take away the moderation of the session. Thank you all so much for joining today.
Perfect. Thank you, Kieran. As Kieran mentioned, Shravya and I are two of the chief residents back in Boston at the Harvard program. It's really an honor to be here, and we're really excited for some good clinical discussion this morning. Just see if I could advance. There we go. So huge thanks to the organizing team. These are Sam, Krishna, Teja.
Next slide, please.
Nikhil, Sam, Shravya. Oh. Is it coming up okay?
I think Teja is sharing his screen. Teja's sharing his screen, Haley. So just tell Teja to advance his slides.
Okay. Let me see. It looks like it's still sharing my screen. Can you see which screen are you seeing right now?
Haley, we're on Teja's screen, but we can switch to yours right now.
Okay, let's go ahead and go. Let's have Teja do it because I'm having a little bit of internet issues over here.
All right, so we're on Teja's screen now.
Teja, are you sharing currently?
I am, yeah.
Okay. And the slide that's coming up is the organizing team. Is that what everyone else is seeing?
It's the case presenter screen. I can change it back to the organizing team.
Yeah, sorry about that. Let me just get out of mine. Okay, perfect. Excellent. Sorry about that, everyone. A little bit of an unstable connection on my end here. So we have some excellent cases. We received a ton of submissions, really interesting cases that I think we can all learn from. And from those, we pulled some that we thought would really be beneficial for some really interesting conversation. So we're honored to have here several presenters, Dr. Kipkirui Yegon from Kenya, Dr. Mapuor from South Sudan, and Dr. Milkias Tsehaye Gessesse from Ethiopia. And then we have a number of faculty as well, next slide, who will help kind of facilitate the discussion, offer some insight into the surgical management of in these cases. So we have Dr. Tsehaye from Ethiopia, Dr. Brian Madison from South Sudan, and Dr. Pierre-Marie Bolli from Haiti. Next slide. And then from Boston, from the Harvard program, we have Dr. Rodriguez and Dr. Wickstead. So this is kind of a brief suggested agenda. Sometimes, the discussion will get lively, but we'll try and stay on time. And we'll go as we go through the cases. And like Kieran mentioned, just a couple logistical reminders. Please, as questions come up during the cases, put them in the chat. We'll kind of be organizing them as we go through to facilitate the conversation, and then use the raise hand function as we go through the conversation. So Dr. Yegon, would you like to go ahead and pull up your slides for the first case?
Okay, hope everyone is okay. So I'll be presenting this case. The patient, so I have no disclosures. Currently I finished my residency last year here at Penn, and I did my med school some 5 or 6 years ago. I'm currently practicing here at Tenwick Hospital. So my case is LB, 24-year-old lady who presented 2 weeks post-RTA. She was a passenger on a boda boda. Boda boda is like a common popular means of transport here. It's like a motorbike, which lost control, sustaining polytrauma. She had been admitted to another hospital. Then after about 2 weeks of little or very minimal being done, she referred herself here. She was otherwise a very healthy female with no other issues prior to this injury. General exam, when she came, she was pale, had this diffuse lower limb edema, from around the foot all the way to the thigh. Gessesse was 15. She was responsive. When we came to the limb, she had the limbs were splinted, but on just removing the splints or just modifying them a little, she had this shortening, left lower limb swelling and deformity, and all her neurovascular exams were intact. She was turned over the pubic area, and apart from that, the systemic exam was remarkable. We examined the genitourinary tract, and she had a Foley, no blood staining, and V and everything else was okay, even at the diarrhea was okay. So she was anemic by the time she was coming, but a little bit of leukocytosis, but otherwise everything else seemed to be within normal. So we did the x-rays, and the x-rays showed this PC2 ring injury, left tibia diaphyseal fracture, right femur segmental fracture, this left femur diaphyseal fracture. So just the x-ray of the right, if you look on the right there, I hope you can all appreciate the neck of femur fracture on that picture. Yeah, I can see Kieran looking very intently. So all of you should. Then you can see the diaphyseal transverse with some little comminution. Then this was the tibia fracture. This was the PC. Of course, looking at the, you can see the widening of the symphysis, and back there on the right, you can of course appreciate widening of the side joint on the right. On this, the femur here also, you can have a peek on the femur, and I hope you can also appreciate the neck of femur fracture on that x-ray. Then this was the initial CT that we did, but of note is this CT we did after some fixation had been done. We'll discuss about that later. Then this was the CT, and now you can all appreciate the neck of femur fracture on the CT scan. I'm sure on the x-rays you're all looking for it. So management, so of course there is the resuscitation, stabilization, hemorrhage control. By the time she was coming, she was out of the acute phase. So for us, it was mainly to resuscitate, optimize her for surgery, and then move on to stabilization. So of course, she was this polytrauma patient. So the discussion is, where do you start? So for us, we elected to start with the long bone fractures. Then after the long bone fractures, we obtained the CT of the pelvis, having have seen the PC2 on the x-ray. But you could see on the x-ray, we couldn't appreciate the neck of femur fracture. So, so we went ahead and fixed the pelvis. So we did this SI screw for the pelvic ring, posterior ring. Then we did the intrapelvic approach, or the stopper, for the anterior ring. Then we, having have seen the X-ray of the femur, or the CT scan, the fracture of the femur after fixation of the shaft, we elected to do open fixation of that femur and do screws. We of course augmented that with a plate. I'll tell you later why that happened. Then of course post-op rehabilitation, looking at the amount of injuries, we first started with wheelchair transfers. Of course, it was important to range whole joints. I gave antibiotics for just the 24 hours post fixation, analgesics. We usually, because of the amount of injury she had, we just thought to anticoagulate her with junior aspirin for about 6 weeks. We discharged her 3 days after, on the 3rd day after fixation of the pelvic ring, but of course it had been almost a week in hospital after fixation of everything else. In 2 weeks we came and we removed the sutures. Then, so this was the pelvic outlet of immediately post-fixation. And then this was the inlet immediately post-fixation. Then this was her on a 6 weeks follow-up. You can still appreciate the slight fracture line still on the neck, but the rest of the fractures look fine. Then this was on 12-week follow-up. The SI joint and the anterior ring look okay. And then here you can appreciate now that the line along the neck is actually on radiology is actually obliterated. Then you can, at this point, after 12 weeks, we started ambulating her. From the point of fixation till now, we just been doing wheelchair transfers. But after the 12 weeks, when we had at least signs of radiological healing, we started a full weight bearing. And currently she is fully walking with all the fractures fixed. So that is just the presentation on this, yeah. So these are my acknowledgements. The hospital, of course, the academy that trained me, and then the Department of Orthopedics.
Thanks, Dr. Yegon. Can you go back to the slide with the fixation just so we can have that up while we do the discussion? I think it would be helpful to have the radiology up just for a point of reference. Yeah, thanks.
Okay. Just a minute. So which radiology did you want?
I leave that decision to Dr. Haley and Dr. Shrabia.
Okay.
Why don't we go to the, let's go to the one with your fixation, probably the first post-op. I think that might be the.
That one. So there is the oblique and the inlet and outlet.
This is good because this will kind of allow us, we can see the text for the discussion too. So looks great. I think we can jump right. It looks like Dr. Rodriguez has already raised his hand, so we can jump right into discussion with him. And then as other questions come up, feel free to use the raise hand function, and we'll get the discussion going.
Hi, I'm Ken Rodriguez. I'm located in Boston. Thank you so much. It's a great case. It illustrates many principles. So the first thing I would like to ask is the order. Could you comment on the order of your procedures and why? What was your thought on deciding what gets done first? Because this is a patient that's now hemodynamically stable. It's been 2 weeks. So this is now all orthopedics. And it's a great opportunity to kind of think about the order of cases and what advantage doing something first renders to the next step.
Our order of fixation, we started with the long bones. The reason we started with the long bones, of course, as you can see in the initial labs, she was anemic. So we couldn't do everything. And of course, the procedures are very tenuous and very huge. So you can't do everything in one setting. But our thinking for doing the long bones was so at least we can have a little bit of ease in terms of nursing care. It was very hard to get her even to mobilize in any way because of, by the time she was coming, she was completely bedridden. So one of our consideration was, let's get the long bones fixed. That way it makes the nursing a bit simpler and easier for people. And also so that we could get at least some of our joints moving. At this point, we had done a DVT and she didn't have any DVT. We had done a screening for that and we didn't have. So we thought at least getting her moving would be a little better for her. So we started with the long bone first before we moved to the pelvis. So our reasoning was just get at least some of the joints moving and making the nursing a little easier for the people who are taking care of her.
So she had bilateral femur fractures because I see implants on both sides, right?
Yeah. So if I'm just sharing, yeah. So I just so she had this tibia fracture, she had this femur fracture, and also she had bilateral femurs. Yes, she had bilateral femur fractures, a tibia, and so on one side it was a floating knee. Then on the other side, it was just a segmental femur fracture.
Okay, so when you did the right side, which was the limb with the most burden, right? They had the neck, the shaft, and the tibia. How did you stage Did you do all the right side in one surgical setting, or how did you do the right side?
So for the right side, we did the tibia and the femur first in one setting. But as I've shown you and I've kept, I had kept, if you look at the CT, the femur neck or femur fracture is very obvious. But we got the CT immediately after fixation of the long bones. But if you want, if I draw your attention to this X-ray, you can see, you can barely notice any neck or femur fracture. And if you even look at the other right X-ray, which showed, you can barely appreciate that. So when we went into the case, we didn't have the CT. So our thinking was it was just a simple diaphyseal fracture that we just needed to stabilize the long bones. Then immediately, the immediate post-op X-ray actually, so I actually didn't put the immediate X-ray after the fixation of the neck of the shaft, but if you looked at the X-rays immediately after fixation of the shaft, you could actually appreciate some widening and some comminution around the neck. So the neck we actually picked up immediately after fixation of the diaphyseal fractures. That is why that was fixed later. So the next time we went in, we fixed the neck and the pelvis in one setting.
Okay, that makes a lot of sense, and it's actually not a rare occurrence. You know, in fact, the ipsilateral femoral neck and shaft fractures are often, the neck is often missed and is not picked up until after you've been doing a few things. So now I understand your sequence. Yeah. And it's always tricky, right? Because in retrospect, had you known, you know, you would have altered the order, right? You would have done the neck first and the femur. Yeah. Thank you so much for that. That I think is very important for
we just had. Oh, sorry, Dr. Rodriguez. We just had one related question in the chat. The CT, could you just clarify when that was done? It looks like it was after the femur fixation, but before the pelvis fixation.
Yes, so the CT, so like I said, our order first was we had the X-rays, we could see the long bone fractures, and we thought we should just stabilize this first, get her moving in one way or the other. Then after doing that, then immediately, in fact, the CT, as she was getting out of theater to go to the ward after the long bone fixation, she had the immediate post-op X-rays together with the CT done, and that's when we pick this up. So the CT of the pelvis was done immediately after long bone fixation. And our reasoning was we probably, and I think if you just look at even the literature, it would make sense why it was minimally displaced, given that I think most of the energy dissipated through the diaphysis. So that is why it was probably minimally. And as soon as the diaphysis was now one whole bone, then you now have that part that is fracture moving. So that CT was gotten immediately after the fixation of the long bones.
So, Dr. Yegon, sorry, Pierre-Marie, I'll let you jump in just a second. There's just some more questions in the chat. I just want to make it crystal clear. So when the patient arrived, you took the patient in and did nailing of the femur and the tibia on that side. And then there's some displacement at the femoral neck, which raised your suspicion. And when you got the CT scan of the pelvis, you also saw the femoral neck fracture. And then in your second surgery, you went back, fixed the pelvis, and fixed the femoral neck, correct?
Yes.
All right. Go ahead, Pierre-Marie. Were you going to say something?
So congratulations. That's a really hard case to do, especially 2 weeks out. Looking at this, right, you had a really good kind of damage control 2 weeks after, which is kind of helped you in a sense. My question is kind of, well, looking at your thought process, you know, what was your surgical approach doing that femoral neck fracture? And then you went to the stop out. Did you do a Watson-Jones? Did you do a Smith-Peet? What was your thought process in fixing it? And then I'm kind of curious why you put that anterior, I guess it's a 2/3 tibial plate to fix it, or what was your thought process?
So we did the stopper for the anterior pelvis, of course. Then we did percutaneous for the posterior. Then for the neck, we did the direct anterior approach, which has been used by some of the joint surgeons to when they are doing some of the direct anterior hip replacements. So we went for direct anterior approach. And the reason we put that plate, if you look at the CT actually doesn't tell what you find in top. And that is one thing that we've been noticing, especially when we go fix this neck of femur fractures. So in the CT, it just looks like a very simple transverse fracture, but in top, as soon as we open that, there was actually comminution of the superior neck. So anytime we tried reducing that, it would collapse into varus. So the reason we used the plate was we needed a way to hold that fracture in a way that it doesn't collapse, and in a way that we try at least restore the neck shaft angle. So that is why we use the plate. So the plate was used to control the varus. Anytime we would try to fix it, it would collapse. So we put the plate there, and then given if you look at the fracture, probably we would have tried another implant, but given that we had already done another kind of fixation down at the shaft, we were not about to take everything down. So we went for, as soon as we put the plate and it held, so we thought the plate plus the screws should be enough fixation to hold and stabilize that fracture. So the reason we used the plate was there was superior comminution, and every time we tried fixing it, it kept collapsing into varus. So we placed it there to at least hold. We used at least hold the reduction at the calca area, then we put the screws to stabilize that.
Yeah, I think that's fantastic. I think I actually did that a couple of weeks ago, especially with high comminution. So that's a really good trick. You kind of flatten out the plate a little bit to not have it that kind of curve, and then kind of keep it in fixation. I mean, keep in mind that this is a 2 weeks out injury, right? And I don't know from the point of injury to your point of femoral neck fixation, you know, how long was that? Because this was your second surgery, if I understand correctly. And so your risk for AVN and any type of complications on that femoral neck are pretty high. So I think trying to fix it as anatomic as possible and then give it a chance as much as it was a good technique. That's a really good case.
There's a really good question here in the Q&A that I think would be worthwhile pulling in here. There's a question from Dr. Solomon Melkamu, who says, if you know the femoral neck fracture before the CT scan, how would you proceed with the order of your fixation? I think that's a very good question.
So if we had known he had a femoral neck fracture before fixation, of course, debate is out there on whether to fix the neck first or the shaft first. I think we can never agree on. Everyone has their, I need the neck first, then the shaft first. The only thing that probably would have changed is our choice of implant. Looking at how transverse that is, the Powell's angle is probably more than 50. So you need screws are probably not your go-to. So if we had known, we'd probably have gravitated to maybe a DHS and nail. We would still have done both dual fixation in terms of we would have fixed the nail, then we would have fixed the neck and the shaft as independent fractures, but with 2 different implants. So normally here we try and the shaft, but not where to fix the neck, then the shaft, or the shaft, then the neck. Everyone has, I think we debate this every time we have this kind of fracture, and consensus usually ends up on either way is fine, whichever you are comfortable with doing first. I think the most important thing is just to try to get them as anatomic as possible. Is the consensus we at least can get to, but whether to start with the neck first or the shaft first or the shaft and the neck, we don't, but here we usually start with the neck, then the shaft.
Eric, that's a good case. Thanks for sharing. I'm more interested in the femoral neck fracture.
Yeah.
You can see that it's you did a great job doing the Smith-Peterson approach. Especially for us in resource-limited settings, sometimes when you don't have access to radiography, instead of leaving the fracture just like that, I think sometimes we go for the Smith-Peterson approach and do as anatomic fixation as possible, because this is the most important determinant for fracture healing, the reduction that we get. I'm just a little bit more concerned about the fracture line, which is sort of a shear fracture. It's sort of vertical, and
Yeah.
I would really be anxious about putting in screws. Have you thought of putting DHS and perhaps try to maneuver the screws on the side plate so that they don't hit on the nail? Because you've done a retrograde nail. I think there will be a space in the model that can, hold the screws. I'm just concerned about the shear force. Of course, the fracture healed very well. It's a young patient, but that's a concern. Using fixed angle device is usually recommended for high shear fractures. Yeah.
Yeah. So, Brian, thank you. So, I'll, as I had said previously, we looked at the fracture. It is actually very vertical almost. And if you look at the literature, Powell's angle above 50, they recommend a DHS. But we had done prior fixation of the femur. And of course, we've done, sometimes you can do a DHS and still try sneak the screws and it works. But the reason we went for the screws is after we'd done open approach and put the plate there, we thought the plate together with, if we combine the plate and the screw should still be adequate fixation. But if we are not to open that, then probably would have done the DHS. But this, remember, we're also doing without, we had already fixed the femur and we didn't know that the fracture was open. And as I've said, if we had known that the fracture was, there was a neck of femur fracture and the shaft, by the time we were going to fix the shaft, I think we would have done a DHS. But given the 2 weeks also, as soon as we fix the shaft, then you can imagine the order of post-op X-ray and your neck suddenly looks very open. And you start wondering, it's already 2 weeks, can we even get this reduced closed? So because we had opted to do open and we put the plate, so the plate being there, and if you looked at the X-ray, her neck is not as big, so couldn't even accommodate 3 screws. So we went for 2 screws, but we thought the plate being there should be enough fixation to stabilize that long enough for her to heal. So yes, ideally it should be a DHS, but sometimes, of course, you change the plan depending on what fracture gives you. And sometimes, of course, trauma, it does what it wants to do. So that is what we ended up with. But yes, if we had known prior, we would have gone for a DHS. But I think what we found in intra-op and how we managed to fix it just informed our, after putting the plate, we thought, do we remove the plate and do a DHS? Then we are like, no, let's just do screws, because you can know how painful it is to actually get that reduced and holding it. So I think that was why we went for the screws.
Yeah, I think it's actually a good job. The fracture went on and healed very nice. So yeah, it's a good learning case.
We do have a couple more questions in the chat. I know Dr. Rodriguez and Dr. Mapuor have had their hands up for a minute, so I'll let them jump in quickly with any comments, and then we can address some of the questions.
I was going to comment.
Can I come in?
Yeah, I think the answer was given. I was wondering how much it displaced during the femoral nailing that prompted you to open it, because you're going into this fracture with a fairly good prognosis. The fracture's been there for 2 weeks. It hasn't displaced. So, in fact, it was so non-displaced that you almost missed it had you not done the CT and noticed it after your initial surgery. So if the fracture displaced a lot during your nailing, then I think it is justified to open it. Otherwise, I would have just fixed it without opening it in order to take advantage of the intactness of the whole thing and not risk disrupting any blood flow. But if it was very displaced when you did the femoral nailing, then it makes sense to open it.
Yeah. So immediately after before the reaming and fixation, it didn't displace as much, but as soon as the diaphysis was in continuity and one, then now all the forces that were going up the femur, I think disrupted that. So by the time we did the X-ray, and I remember the day immediately after getting the X-ray, it was a debate of, do we even fix this? Is this a femur neck fracture? Because no one wants to go back there and fix a neck or femur fracture that is 2 weeks old. So in the morning, you can imagine the great debate of, does it need to be fixed? But on X-ray, unfortunately, I wish I would have put that. On X-ray, actually, the superior neck, most of it was actually almost like a wedge kind of comminution immediately. So we thought leaving this, very high risk of collapse. And then the question was, do we want to come fix this a month later after it has collapsed? So everyone was like, I think 2 weeks is still not your ideal, but it's still better than a month or 6 weeks later of coming and seeing it collapse completely. So we thought, since we'll be there, let's just do something so that you get to sleep at night and get.
I'm not arguing fixing it. It should be absolutely fixed. I was arguing why open it and not just try to restore.
The open was because the displacement was so much, and actually she had already started forming colors. So by the time we got there was some colors. So you can imagine the fixation of the diaphysis was enough to displace the fracture. Unfortunately, not enough that we could do it closed. So we tried doing all the maneuvers, the lead bet and all the maneuvers you can try to get that reduced, but it's refused. So
that makes absolute sense. Thank you so much for clarifying that.
Yeah.
Can I come in?
Dr. Mapuor, go ahead.
Yes, thank you. I just feel like we need to make something clear for the audience, the series of what to fix first and what not to fix first. In case of a femoral neck, femoral shaft, and a tibia on the same side, I think fixing the shaft of the femur will allow you to do manipulation side that you fix the neck. So you start with the shaft, you manipulate side that you fix the neck, because tibia already, you have a cluster of Paris. You can put a back slab until you fix the femur shaft. You do manipulation side that you fix the neck. So I want the audience to know that is the shaft first, followed by the neck, and then later on you go for the tibia. And then the other things we need to understand is femoral neck fracture, whether they are missed or not, is a matter of medical legal issues, because somebody may tell you that is when you are fixing the shaft with the nail that you cause iatrogenic fracture to the neck, and that could happen. And that's neck fracture could be due to a road traffic accident, which is, we can see at this case is a high energy trauma. So that could be a neck fracture. So what I want to say is, in our setting where there is no, or when the city, where the city is limited, you can refit the X-ray such that you don't miss any fracture. So doing a pelvic, epipelvics, you can also do a femoral neck, the right hip X-ray, epi and lateral. So in these high energy patients, if the neck is fractured and it's not displaced, you will be able to detect it instead of missing it until 2 weeks later, for example. So that's what I want to add. Thank you.
Yeah. So
I just want to add
yeah. Okay.
Yeah, I want one quick is looking at the femoral shaft fixation with the femoral neck. You use I suppose it's a fin nail. So it's probably a sign field nail that you use. And so when you're reaming with a sign field nail on a retrograde approach, it's a hand reaming, right? And so you have to be careful not to over ream or kind of make too much of your hand motion on that specific nail system, because that has happened, that just like Dr. Mapuor said, by doing that reaming, you may eventually not necessarily, create the iatrogenic femoral neck fracture, but kind of displace it more than it was initially. So that was my comment on that. So just be cognitive of you reaming with a hand straight reamer, because it's not a drill powered reamer, and that can cause itself iatrogenic femoral neck fractures as well. So
yeah, so like I think it was Brian. We also do the same immediately after all neck or femur fractures, or immediately after all shaft femur fractures after fixation. You always try to get an X-ray that shows the neck. Because sometimes you can miss that. And of course, if you've already fixed your shaft, you can usually go back ahead and fix the neck. Like Brian has said, and I think I've said, I think even amongst us here, we don't yet have a consensus for sure how to approach that. All we know is we need both fixed. And there are some guys who think neck first because you need to get that very anatomic. Some guys need get shaft first because you can use that to help you with the reduction. But we've done both of doing the neck first, doing the shaft first, and well done, all of them. You get good fixation, good alignment. But preference, of course, and if your center does prefer the shaft than the neck, it's totally fine. Then the approach we did, the previous person who asked thought we didn't do a Smith-Peterson approach. We did an anterior, the direct anterior, the same incision you use when you are doing a direct anterior approach to the hip for anterior hip replacements. I think it's if you know how to do it, might be a little easier with less dissection. But if you're comfortable with the Smith can also work perfectly fine for this. And I think everyone knows this is very common to miss, and you can get up to, I think if you look, literature shows up to 20 to 30% of neck or femur fractures that are undisplaced are missed. So that would mean every 7 or 8 of us in every 10 people would actually miss this initially. So missing it is quite common. And there's no problem if you miss it. I think if you miss it, the bigger issue is to just recognize and go back and fix it. But it is very common even with the most experienced guys, because 20 to 30% of it getting missed is quite high. So it's actually, you can miss it, but the most important is once you recognize it, you do something to fix it.
I agree with you, Dr. Yegon. I think that, it's very common to miss these things. I think the only thing that could have changed is if you'd gotten the CT scan first, and then you would have recognized the non-displaced femoral neck fracture. And what you could have done is you could have fixed the femoral neck fracture before it got displaced, maybe done that closed, and then nailed the femur. But I think when you were nailing the femur, you probably displaced the femoral neck fracture, not knowing that it was there. And then that caused that increased the likelihood that you needed to do the open approach to get a good reduction, because probably that comminution had become more apparent. So I think the discussion about the femoral neck, femoral shaft is fantastic. I really love it. But I do want to shift the conversation a little bit back towards the pelvic fracture, since that's the topic of today's conversation. We do have quite a few wonderful questions here about that. My question to you, Dr. Yegon, is was it very difficult to get the reduction now that you're 2 weeks out? And also, what was your rationale for the approach? This is the question from Mustafa Masai, using the modified stopper approach instead of the simple anterior approach to the pubic symphysis. Can you talk a little bit about how you got your reduction, how you did your approach?
So our reduction we did, we used so it was 2 weeks out. So a little bit difficult, of course, given how long it was a little open. But we did a funnel stain incision, direct, then open the fracture, reduced. So we used the young bluth clamp to actually try to bring that together. Then as soon as we had that together, we went for, then of course, if you can see here on this CT, you can see that also the posterior ring was also open. So we went for, after that was, we reduced the young glute clamp. Then once we held that, we went and put in the SI screw. Then once we put the SI screw, then we came and plated anteriorly. So the reduction was a little bit harder, but not so hard, because at least what you had, at least with the posterior ring, at least the anterior ligaments being disrupted, it was hinging around the posterior ligament, so you could actually have it closed. So it is an open book. We just closed the book, held it, put a screw back there, then put a plate at the front. Yeah, so that was rational. The screw at the back, some people would say the plate alone is enough, but there was a study we saw that actually showed the risk of failure for the plate if you don't do some posterior fixation is a little bit significant. By that is the plate breaks because of just the hinging around the posterior, and it's an APC2. So if you had, I think there was a video by Dr. Weaver, and if you looked at it, APC2s are unstable, so they need fixation. So if you don't have an SI screw, you can usually do an open and put a plate. But if you're fortunate and you have a cannulated screw and you can do it safely, you can actually do an SI screw. So for us, we just went for the SI screw and the plate to just augment that fixation.
Yeah, I think that's a wise decision. Were you able to get the reduction in the back of the pelvis without having to do like an intrapelvic approach, or did you have to open that window up?
We didn't have to open that window up, which was nice. She was a big lady, so we didn't want to open back there. But
Nice.
as soon as, and that is why we didn't plate before, so that in case we needed to do a bit more compression,
to adjust it.
Yeah, so we could adjust it. So we went for the posterior then as soon as, and I think if you see this X-ray here, you can see actually it's well reduced. So as soon as we had that, the inlet outlet showing it's very well reduced, of course you praise God and move on. You don't go back there and put a plate. So once we put the screw and we tighten and it closed well, we just put on the plate. So we didn't have to open to reduce that. Yeah.
No, I think you did a nice reduction there. So we have two other fantastic cases, so I don't want to lose the time to talk about those, but I'll give maybe 30 seconds for our faculty members to give some final comments on this case before we move on. And just a reminder, all faculty, please feel free to type your answers to any of the questions that you see in the comments in the chat. Any last comments, K-Rod? Dr. Milkias, you raised your hand earlier. It's Dr. Hailu. Yeah, please, Sammy, go ahead.
Yeah, so thank you. I think a couple of messages that I want to pass on. And the first thing is we should understand the fracture nature before we indulge into fixation. So we should have got, I think, a CT scan of the pelvis before any sort of planned fixation. That way, you could have addressed the femur neck percutaneously without having to open it. And then when you go to the pelvis, can you go back to your CT slides, the axial slides that you have put on? Yeah, can you go to the sacral side, sacrum? I think you had a CT scan with the sacrum. Yeah, okay. Yeah, so it is a still slice, right? I guess we could have seen the. So if you see the posterior side seems to be opened as well, and even the contralateral side might have also an injury there. So it would have been good to actually stress it intraoperatively to have a better picture. And then the other thing that I want to pass on is, you used plate fixation. If you go to your post-op symphysis pubis plate, before you do your plate fixation, you said you used what did you use for reduction aid? You clamped it or?
Yeah, we clamped it. We used the young glute clamp to just to bring it back together. Yeah.
Yeah. So I guess what typically happens after a few weeks is the symphysis pubis might have fibrous tissue, so you might need to clear it down a little bit more. So if you see there's still a residual gap in the symphysis pubis, if you go to your post-op X-ray. So there seems to be a residual symphysis pubis gap, and now that could actually lead on to a few things later on in life. Because you also left the screw holes empty, the chance of this breaking increases significantly because you also have only one screw at the back. So I guess it's good to have 3 screws on either side of the symphysis pubis, and then to get a better reduction of the symphysis. If you get a good reduction as much as possible, that would help, and never to leave any hole in the symphysis. One of the questions Dr. Salamon raised was that. And then, to have a better understanding, you could also stress it before any fixation. You could stress it intra-op to see if the contralateral side is also opening up.
Great points. Good teaching points, Sammy. Thank you so much. All right, just last few comments, and then I think we should move on to the second case, if that's okay with everybody. We could talk about this one case for 90 minutes, I think, easily, Dr. Yegon. I just want to commend you. You did a fantastic job managing an extremely complicated polytrauma here. And I think all these little teaching points and things are for all of us to just get, the really maximum amount of teaching from this case, which is great. Really well done. I really commend you.
Yeah, thank you.
Yeah, and can you go to the last slide where you showed the final follow-up at 6 weeks? And did the patient end up healing this femoral neck fracture?
Yeah. So this is at 6 weeks. You can still see there is no signs of radiological healing. You can actually still see the fracture line on the superior neck. Then this was at 12 weeks. You can see that line you can barely see it. And at this point, no pain, gone. She healed it. So
that's great. That's great. A fantastic outcome. And I think the product of a very thoughtful procedure. And I think there's some things to learn, right? Like Sammy went over, trying to get that really good reduction, more fixation in the pubis, which obviously wasn't a problem for this patient, but can be a problem in some cases for sure. And then I think diagnosing the femoral neck fracture first, teaching point for all the residents on the line. Very, very commonly you see this, especially in high energy injuries with a femoral shaft fracture. So I think keeping that in mind, and if you were able to, despite having limited resources, get the CT scan ahead of time, that would have really helped, I think. Yeah, Dr. Milkias, do you have one final comment before we perhaps move to the second case?
Yeah, actually it's quite related one. So I think it's very nicely done, and then a female, yeah?
Yeah, it looks like a fin nail.
Yeah, that's a female. Can you go to the last slide, control X-ray, follow-up X-ray? And my question is that did you have a difficulty of inserting the fin nail, probably if it was a little bit big diameter, so that you have to hit it in order to insert it and make it snugly? So probably could that be one risk factor for the femur neck fracture, or displacing it furthermore if there was any undisplaced one, is one point that I want to raise. Thank you.
Yeah,
I
think putting in the nail is likely what displaced the fracture. But like I said, we didn't have prior knowledge. If we did, I think we would probably have been more careful. Though, whichever way we look at it, I don't think there's any way to put in a nail without displacing, because the only way to put in a nail, we have to hammer it in somehow, whether we drill with power, we rim with power, or whatever. But the actual putting in the nail, even if you over rim, you still have to pound it in. And that pounding sometimes just displaces. But of course, the fin, because you need it to be snug fit, might have caused it to displace a little more. But if we had prior knowledge, probably would have changed what we would have done, but we didn't. And looking even at the prior X-rays, we didn't see anything. But yeah, I think putting in the nail, whichever way, would still have displaced. But I think the fin, because you want it snug, probably displaced it a little more.
Yeah, still my worry is about causing an iatrogenic femur neck fracture. I mean, we all have faced while we are putting a fin nail, we sometimes face difficulty if the fin nail is quite bigger. It would be difficult to pull it out, and it would be difficult also to push it in. So that's my worry again. I mean, definitely we can't rule out that, or it's quite common having a femur neck fracture in association with a femur shaft fracture, but still, if the fin is quite big enough from the beginning, probably it could also predispose for an iatrogenic femur neck fracture. Not for this specific case, but just raising the point that we could face probably in the future. But this very nicely well done case. Thank you so much for the presentation.
Yeah, thank you. Tremendous job, especially to do this all with limited resources. And I think just you said 1 year out of the end of your training. I think this is remarkable, like truly remarkable technique and everything. Really well done. All right, so let's move on to our second case, if that's okay with everybody. Dr. Mapuor, I think you're up next.
Okay. Thank you, everyone. That was a nice discussions. We all learned a lot from each other. My name is Dr. Mapuor. I'm an orthopedic surgeon practicing here in South Sudan. I'm happy to participate in this webinar, complexly lower extremity trauma, particular pelvic ring injury. So my disclosure here are the implant we use to treat this patient are donation from Sign Fracture Care International. There is no conflict of interest. So pelvic ring injury is my case today. So to give you a clue, this patient is a 37 years old male who is a bodyboarder rider. So bodyboarder is common here in East Africa. It's used for commercial purpose and it's used for transport mainly. So this young man is a bodyboarder rider. He was involved in road traffic accident and sustains an injury to the pelvis and the left femur. So he presented to the hospital within the first 30 minutes of his injury. During an assessment, he had a stable vital signs, which you can see. So to understand the pelvic ring anatomy, we have to understand the bony anatomy of the pelvic. So pelvic is formed of innominate bones. We have the ilium at both sides. We have the sacrum posteriorly, and extension of the ilium toward the anterior aspect. We have the pubics, and we have the ischium. And you can see here at the back of the pelvis, there are two joints behind, which is the sacroiliac joints on both sides, and anterior there is symphysis pubis as another joints. So the stability of the pelvic ring is not because of the articulation, it's because of the ligamentum complex that bind it together. So we have three ligamental complex that maintain the stability of the pelvic rings. Posteriorly there, we have the sacroiliac ligament, and is the most strongest ligamental complex that hold the pelvic together. At the same time, at the posterior, we have the iliolumbar ligaments. These are from the L4 and L5 to the iliums. And those, when they are injured, it is an indication of this injury was due to severe trauma. The another ligamental complex is the anterior ligamental complex, and that is the pubic symphysis, and that's a top fibrous cartilaginous disc that bind the pubic symphysis together from the anterior aspect. When you go down to the pelvic floor, we have a pelvic floor ligamentum complex, And these are sacrospinous ligament, which is oriented in a transverse manner, and it resists external rotations. And we also have sacrotuberous ligaments. These ligaments is oriented longitudinally, and this resists the vertical translation of the pelvic. So inside the pelvic rings, we have the neurovascular status that are all arranged within the pelvis. Are you getting me? Yes. So the most important here, which we have to understand, is the verifications of common iliac artery into external iliac and internal iliacs. So our main aim is at the internal iliacs, which is divided into anterior.
I'm sorry, we're getting some feedback here. Dr. Mana Abdul Namran, can you please mute yourself? There we go.
So,
all right, thanks very much.
Yes, so the internal iliac is divided into anterior and posteriors, and the most common injury basically is the posterior branch of the anterior branch of, the posterior branch of the internal iliac's division is the most commonly injured. And within the pelvic ring also, we have sacral venous plexus, and this is the most common source of bleeding in the pelvic ring injury. The goodness is this is a potentially closed space, and when you have an open book pelvic fracture and you close that book, that will cause a tamponade and will stop the bleeding that is occurring inside there. Another thing we need to put our mind into is what we call the coronary motus, and that is for the surgeon who are practicing or doing surgeries for a case of pelvic ring injury, particularly when you go into anterior, want to fix the anterior aspect. So you have coronary motus. This is an osmosis actually between the obturator artery and the branch of external iliac artery. So the poems and osmosis, and they have a small calibry. So their bleeding usually cause headache to a surgeons when you are doing surgery. So the principle is find those coronary motus space before they find you. So that's the principle. They are located actually between around 6 to 6.2 centimeter lateral from the symphysis pubic. So you have to find coronary motus before they find you. That's the principle. So to come back to this history, the plan of management, do we need more X-ray, for example, at this X-ray that I projected? Yes, of course, we need X-ray. This is an AP view of the pelvic. We need to go as far as doing inlet and outlet view so that it give us more details on the fracture and so that we don't miss any fracture. We of course need a pelvic CT so that it will detail us the fractures, and it will help us in planning our management. So doing, and again, because this is a polytrauma or a multiple injured patient, we have to do, for our residents, we have to do trauma series, doing a chest X-ray, cervical spine, abdominal ultrasounds, pelvic X-ray, and then the lower limbs. So you have to follow this trauma series so that you don't miss any injury, because this multiple injured patient, whether it is stable now, it can change, the situation can change anytime. So you have to use the resources you have to do the X-ray. For my side, the CT scan costs a lot of money here. So not every patient that can afford, but you have to do it if the clinical situation required. So doing an X-ray or doing CT scan, doing an X-ray will help you have a classifications, and classification is mainly a communication language between the surgeons and those who are practicing in managing this patient. So Young and Berger's classifications is used for pelvic rings injury. So the most important thing here, if you start from the top, is the LC, which is lateral compressions. So anterior injury or the Rama injury. So we have a Rama injury here. So the LC1 is a sacral fracture on the same side. The LC2 is a crescentic fracture on the same side of infarct or of injury. And the LC3 is a combination of 1 and 2 plus the contralateral open book pelvic fracture. The second shear on the row is the anteroposterior compressions injury. And the third is the vertical shear, which you can see here. So when you come to the management of this patient is after you clinically reassess the patients, you understand the patients, you have an X-ray in hand. So what is important here is the application or when you apply the principle of ATLS, because these patients are clinically unstable, or they may be clinically stable now, but in a few hours they can change definitely, because you may not seen what is going on inside the abdomen or inside the pelvic. So the process of assessing them is by applying ATLS principle. Primary survey is seeing the airways by monitoring the circulation and also by monitoring the ventilation of the patient. Secondary is breathing. Breathing, you check the chest while also don't forget when you assess the airway, you maintain the cervical spines. Breathing is monitoring how the saturation of this patient is. Circulation is assessing, put your hand in the pulse of the patient, see whether it is straight and rapid pulse. And D is actually exposing the patients while maintaining the hypothermic condition of the patient. So you have to expose all the patients as you expect. You see the genitalia, you see the anal orifice, you see also the urethra, so that you don't miss any open book pelvic fracture or any bleeding through the urethra. So you have to expose your patients. While doing ABCs, you have to continue to resuscitate the patients. And then after that, you go to primary, secondary survey. After finishing the secondary survey, you can go back again to primary survey depending on the clinical status of the patients. Then you reassess the patient again, do interventions, and then plan for definitive management. So during this survey, you may be wanted to put a pelvic binder if you see the patient need a pelvic binder, because not all open pelvic fracture that need a pelvic binder, but there are most common things that need pelvic binder. For example, an open book pelvic fracture, you need also to put the pelvic bag to close the pelvic, so that any bleeding inside there will be arrested, and it will the vital sign will be restored or be stable again. Now, before I go back to that, let's discuss this X-ray here. This patient that I present here, you have here a disruption of symphysis pubic. You have here on the left, on the right side, you have the SI joint is disrupted. You have here on the left side, the iliac wing is smashed. There is a fracture here, and at the same time, you have a subtrochanteric femur fracture. So these are the things we can see here on this X-ray. And if we do, I also have an inlet and outlet view, which also helped me to see the sacral fracture here. And also they can tell me the extent of the iliac wing fracture here. What we didn't do is a CT scan, but I think CT scan was important in this patient, so that it details the kind of sacral fracture that we have here. But due to financial reason, and the hospital doesn't have the CT, so we couldn't manage to do the CT scan, but we were content with the X-ray that we have to manage our patients.
Dr. Mapuor, we're hearing a complaint from the audience about the amount of background noise on your side. Is there a way to quiet down the setting there? We're hearing a lot of sound from your side.
Yes. Okay.
Thank you.
Yes.
All right, Dr. Mapuor, please continue. Yeah, let's get into the case so we can get to the discussion.
Yes, so this is an X-ray of which I describe all the injuries, the disruption of symphysis pubic, the vertical shear. We can see here there's disruptions of the SI joint with injury of the sacral, and we have also the iliac wings fracture here, and we have the left side subtrochanteric femur fracture. So this is after we went in, we decided to fix the pelvic from anteriorly using the panosteel approach or the stop approach by putting a plate and fixing it. And then at the same sessions, we went in and also nailed the subtrochanteric femur fraction.
Oh, I think, do we lose Dr. Mapuor? I think we may have lost the internet signal for Dr. Mapuor, unfortunately, but I can still see his slides up here. Sammy, are you there? I just wanted to bring up the point that you had brought up earlier about like the multiple screws on either side, like 3 screws on either side of the symphysis pubis. That's another teaching point, I think, here. I'm just curious how Dr. Mapuor ended up nailing this femur. Did he have to flip the patient to a lateral position to do that? I'm sure he probably did.
See,
Yeah, I guess we have lost him, huh?
Yeah, I think so. I think we lost him.
Yeah. So we can still discuss about the case though.
So I'll try and at least pull up the X-rays and we can start the discussion.
Yeah, sure.
Yes.
Go ahead, Sammy, please.
Yeah. So in terms of number of screws that we use, especially if you don't know what's going on at the back of the pelvis, it seems like his X-ray shows a left side iliac wing fracture, but he might have more injury going on. In those scenarios, and if you don't know what's going on at the back clearly, and if you cannot fix the back side, it would really be much more important to have a robust fixation in the front side. But in cases where it is relatively rotationally stable-ish, like a B type of injury, and those injuries we might consider sort of 2 screws, but to the most part, even when we have fixation at the back, 3 screws might be and biomechanical. It is superior, obviously, and especially when you don't have any fixation happening at the back, at least 3 fixations. And if you see the old literature, you actually see what we call a 90-degree fixation of the anterior pelvic ring, where you put a plate both on the superior part of the symphysis pubis and also on the anterior part of the symphysis pubis. So robust fixation definitely helps us. And I think the other point I want to raise is in settings where CT scan is not readily available, I think it's good to utilize inlet outlet views and to maximize the visualization of the injury pattern, and it will give us a better understanding of the fracture and better planning for fixation as well. Back to you, Kevin.
Yeah, great comments. Thank you. Pierre-Marie, any comments from the last case that you wanted to bring up?
Yeah, I think that it's a good fixation, especially in a very limited setting. One comment I would say in terms of the position that you asked a few seconds ago, I would have in this particular case, I don't know if he was out. He was out for how long again? You don't remember?
Well, we have the slides here. Do you want to go back to the slide that showed how long the patient was before they showed up?
I mean, from time of injury to fixation.
Yeah, I don't see it in the slide, so I'm not sure if you mentioned that.
So if it's, I completely agree with Sammy. First of all, the anterior plate, as much glue as possible to avoid that middle break down, with all those forces. So what Sammy said is actually really good. The other thing I usually do, because it's very hard to do a sine nail in a supine position,
Yes.
right? basically, unless you put it in kind of an abduction, and if the patient is a big patient as well, it's difficult. So what I usually do is kind of semi lateral, not a full, just have enough space to do it, and then to do that fixation. As far as the pelvic injury, so for the iliac wing, right, you can see that there's this fracture line on the ASIS, and that's why my question is how far out is it, right? Because if it's like 2 weeks, or if it's 3 weeks or more, right, then I'm not gonna worry too much about it. If it's less and I don't have a CT scan or anything like that,
Yes.
I would do a lateral window, right, all the way up to the ASIS. And I would kind of go down and see how that iliac wing is, and then kind of fix it any way I could. If it's a straight line, because it looks like it goes from the ASIS and then kind of wants to go up. Maybe that's me looking at the AP X-ray. And then if I can put a couple of screws, like Skyfer screws or some type of plate plus 1 or 2 screws to fix that, I would. And even if you do like a ASIS screw fixation, like you would do an ASIS osteotomy, and then so you could always do that, like kind of be worried about the nerve a little bit further down, and then just kind of put 1 screw to keep that in place. That would be good. That is if it's an acute, if it's in an acute setting where you're doing this less than a couple of days out. But if it's delayed, right, and then you're in a difficult setting, definitely the inlet and outlet views will help you. Definitely follow what Sammy says in terms of anterior fixation, and then just make sure that I'm kind of curious. Did he do it in one shot surgery, or he did it in 2-part?
Well, I think we have Dr. Mapuor back on the line.
Yes.
Dr. Mapuor,
Yes.
yeah, please.
Yes. Yeah. So sorry for the noise
That's
and
okay.
the internet issues. Yes. So actually, at where I was. For this case, we actually do it outpatient do present late. So what the 30 minutes I was telling you is where the patient was seen first, and then that patient was referred to our center, and that is actually the second week into when the patient has an injury. So what we did was the femur was on the tractions, and then we did pelvic fracture first, because when you see the x-ray, it was terrible in a bad shape. So that's why we decide only to fix anterior and leave the posterior, because it's 2 weeks out and we don't have CT, and we don't want to risk much. So that's why we decide to fix the patient, the pelvic anterior, and leave the rest. And also putting in mind, the third day we fixed the femur, and we thought this patient is not going to bear weight for a while, for at least 6 to 8 weeks. He will be on a wheelchair because of femur fracture and the pelvic fracture. So that's why we didn't decide to bother to fix posterior, or also to fix the iliac wing, because 2 weeks down the line. Thank you. Thank you. So this is an X-ray.
I just want.
Go ahead, sure.
Sorry, I was just, I see that Dr. Rodriguez had his hand up, so I was going to give him a moment to comment and then keep moving forward.
Thank you. I was just going to point out, I think it came up just now very well. The acuteness is important, right? Because if you have a fracture like this one that involves a potential dissociation via the crest fracture, when you reduce the anterior ring, you can displace the crest fracture. So perhaps in an acute fracture, you might want to address the crest first, when you can actually index by looking at the fracture, the reduction of the crest before you close the ring, as long as, of course, the patient is not in distress or bleeding. But you're going to have to do that otherwise. If a fracture, you can close the ring and find out that you've displaced significantly your crest fracture, and that's actually might be harder to do later on.
Can I, as a non-pelvic surgeon, can I ask a question here? I mean, from my perspective, this fracture on the left iliac crest seems like it may extend back towards the SI joint. Is that something that you worried about at all? And when you were doing this case, I mean, it feel like you must have had to do this supine and maybe get windows on either side intrapelvic to look down at the SI joints. And is that not an opportunity to maybe plate across the SI joint anteriorly or to put screws in? What was your thinking there, Dr. Mapuor?
Yes, if the patient present acutely, that's what I will do, because I have to fix that, because that is extending up to the SI joint. So I would open this patient from the lateral window, fix the SI, fix the pelvic wings, put also the plate that goes to the SI joint, to cross the SI joint. I would have actually prefer putting 2 plates for this iliac wing fracture, one down toward the femoral, the head of the femur, that pays downward, and then the other one crossing toward the SI joint. That's fracture on the left side of the left iliac wings. The SI, the sacroiliac destruction on the right side, I would have actually put in the SI screw if this patient present acutely. But my patient present 2 weeks down the line. That's why I decided to leave everything, only fix anterior. Thank you.
Gotcha. Can you show the final outcome for this patient? I think you have some slides on that, and I think we could probably discuss this more, but I do want to get to the final case.
So this is 6 weeks down the line. This is 1 year down the line, and I have a video here of the patient walking. The one, the back, he's walking. You can see from the back, he's walking comfortably with no problem. Yes. So that's
fantastic.
The video again.
Yeah, fantastic. Can we play that video? Yeah, wow. Wow, that's a remarkable outcome, actually. Really. Great. So I think a good teaching point for this one is that the acuity of the fracture really matters. You know, how much fixation you'll end up needing, and also when you're doing the reduction. Very, very important points. And thanks, K-Rod, for that. Well, just for the interest of time, since we're getting kind of close to the end of the session here, I do want to give enough time for Dr. Milkias to give his presentation, and we will go a little bit over. Dr. Mapuor, we'll continue to discuss yours at the end. I just want to give respect for everybody to give their presentations, if that's okay.
Thank you.
Thank you very much. Good case. Dr. Milkias, are you there? Can you give your presentation now?
Okay, thank you so much. So okay, can you see my slides?
We can. Please go ahead.
Okay, thank you. So I'll be presenting on a case of a patient who had complex pelvis and lower extremity injury. And I have no disclosure to make. And she is a 19 years old female patient who came after a fall down injury of 3rd floor with a suicidal attempt. She's a non-epileptic patient. And then she was admitted to the emergency. And according to ATLS protocol was applied with a primary resuscitation and temporary stabilization. And the thing which I would like to discuss here is about should we address all the fractures at the same time, or if we have to order it, do we have to order, and about the timing and which fractures to address first. And this patient had unstable pelvic fracture with a complete right side sacral fracture, acetabulum fracture with transverse and posterior wall, right perotrochanteric fracture, intertrochanteric and femur neck, and pelvic fracture as well. She had quadrirami and sacral fracture, of course, and right femur shaft segmental fracture. And she had right tibial plateau and right calcaneal fracture as well. So other things that I would like to raise is about the what complications to anticipate, or what complications could we face on staging the surgeries. And then, sorry. So this is the case. You can see the pelvic injury, a sacral fracture on the X-ray with obviously visualized trirami fracture, and I think she had also one left side lower rami fracture. And here we can see, if we go posteriorly, the iliopecinal line is disrupted, and then the posterior wall and anterior wall lines are disrupted on the around the roof. We can see also here probably impaction of the sorsal of the acetabulum, and then an intertrochanteric fracture, and which extends to the neck, which is quite comminuted, and we have also here a femur shaft fracture. So she came with a shock, and she was resuscitated and kept in the ER for about 5 days, and she was transferred to the Orange after she was stabilized with her vital signs. And we put a proximal tibial pin traction and posterior gutter. And here is her CT, which shows complete sacral fracture and transverse L5 process fracture, and quadrirami fracture with acetabulum fracture, and which we have already described it on the X-ray, is already seen on the CT scan. And then we planned about options of fixation and what implants to use. And for the shaft as well, shall we use a retrograde and separate implant for the proximal femur, or shall we use a single implant which addresses the pertrochanteric fracture and then the femur neck fracture and the shaft fracture as well? So then we went so these are other additional images of the patient. And then what we did was we positioned the patient supine, and then we addressed the lower limb fracture initially, and we put her on traction table, and then we used a long PFN nail with a helical blade addressing both the pertrochanteric femur neck and then shaft fracture. After we addressed those fractures, then we disassembled the traction table, and we put her on a proper another OR table, and then we went for the acetabulum fracture. So we used an iliofemoral approach, and then the modified stopper approach. We passed a J plate, and then we fixed the anterior acetabular fracture, and for the posterior extension, we used a posterior column screw. And then finally, we inserted our iliosacral screws on S1 and S2. So this is an immediate post-operative picture. And then this is a 1 year and a month's follow-up showing that the femur shaft fracture and then the pertrochanteric fracture has healed very well. And clinically, the patient was ambulating comfortably without support. But as I mentioned earlier, she had also a tibial plateau fracture, which is not that much displaced, and a calcaneal and talar fracture as well. And she developed, during her follow-up post-operatively, around a week later, she developed a lower limb DVT, so that we were not able to manage the other additional fractures. So the tibial plateau fracture was not that much displaced, and then the ankle and foot injury has to be followed conservatively, and eventually patient developed some chronic osteomyelitis of the calcaneus, but she was able to ambulate. Otherwise, she was very thankful and a stable and a happy patient. And I would like to make an acknowledgement to the orthopedic residents and all operation theater staffs of Abet Hospital. So thank you.
Wow, fantastic case. I think lot to discuss there. I think one of the first questions that we're seeing in the chat here is the pelvic ring or the acetabulum fracture. Which did you fix first in your order?
Okay, so it depends. Ideally, it would be good to fix the pelvic ring fractures, I think, and then we can address the acetabulum fractures.
And do you mind
So,
pulling up the post-op X-ray that you had, just so that we can see that while we discuss?
okay.
Yeah, that'd be great. Yeah, thank you. Yeah, Dr. Haley and Dr. Shravya, go ahead. Any comments from the faculty on these two cases? K-Rod, go ahead. K-Rod, you want to unmute yourself? K-Rod, we can't hear you. Sammy, are you there? Are you able to make any comments on this case? I know that you see so many of these in your practice.
Yeah, thanks, Kiran. Yeah, so good job, Mike. So you did a good job here.
Oh, I can
And
go.
you know, so if so for the question of which one do you fix first, it really depends on the personality of the fracture, whether you fix the acetabulum or the pelvis. I know in the traditional way of teaching, where Luther mentions about starting from the back and building the block down along the way. But in cases when anatomic fixation might not be achievable, like this case where the sacrum fracture, you might not be able to do anatomic fixation unless you do it open. It would be it's a good thought process that Mike did the acetabulum before the pelvis, and I would do exactly the same. I would do the acetabulum first and then fix the back. So your patient should be happy. And obviously, if you closely look at the head, it seems like the patient might have had some cartilage damage. Were you able to see the femoral head intraoperatively, Mike?
No, we did not see the femoral head intraoperatively. But yeah, you're right that it looks like she has some head compression. And then, but we had to open with a lateral femoral and then stop our approach. But we are not able to visualize the head intraoperatively.
So you osteotomized the anterior spherical spine, obviously, right?
Yeah, we osteotomized
Yeah,
and fixed it to screws. Yeah.
Yeah. So that's actually one of the approach you could use to have a better visualization of the fracture site, right on the close to the dome, and you can actually use your lamina spreader to open up the fracture site and visualize the head. You can clear up and maybe do subcortical, some drilling on the damaged cartilage that might help with some recovery of the femoral head. But otherwise, you did a good job. Well done, Mike.
Thank you, Sam.
I was wondering about what's going on in the sourcil. You have for a second there a three-dimensional view of it. Can you go back to that slide?
Second, sorry.
the three-dimensional. Do you have the three-dimensional CT?
Oh,
The
okay.
CT
All right.
scan.
Yeah, sure. All right.
And then you show that.
Here.
Okay, so it's unclear what. So there seems to be a high posterior wall component there.
Yes, yes.
I
There
was
is.
wondering so I couldn't tell if it was the head or the acetabulum that was abnormal. Did you address anything in the posterior wall here? Because that's a very hard site to fix anything, because there appeared to be some marginal impaction superiorly and a very small amount of bone. Those are really hard to stabilize. But then in your poster films, it looks the joint looks remarkably concentric. So I wasn't sure. So
Yeah, thank you for the comment. Yeah, we have noticed there was a high posterior wall fracture. So what I was thinking was probably after reduction of the anterior column and transverse fracture, probably it would go into a good place, or else I was planning to address it with 1 or 2 screws going from the medial part of the acetabulum towards the lateral side. Well, that was one plan. The other plan was to address it with a separate, probably Gibson incision, so that we can apply small screws and or else with spring plates. But we did all the fractures in the same setting, and it took us quite long time and lots of CRM exposure and so on. And then I finally decided to kind of accept it, and then I'll probably go for the control X-ray. And when we see that, we just accepted the control X-ray, and we did not want to go for another surgery for the posterior wall fragment or fracture.
I think this is an amazing case. Thank you for sharing. In terms of the order of fixation here, did fixing the femur fracture help you get the head out of the way to assess your acetabular reduction? And like, if the faculty wants to comment on tips and tricks for how to get the head out of the way, especially in impacted fractures like this, to be able to assess your acetabular fixation intraoperatively, that'd be great.
Yeah, that's I can get on that one. That's actually a really good question. That was gonna be my point. To ask how did he get that head out of the way initially? Maybe he could answer that first, and then we could kind of comment on tips and tricks to do it. And Sammy alluded to did he see the head? And if that would be an indication from you saw a surgical dislocation if you were gonna have to do this posteriorly. So how did you get that head out of the way to kind of visualize a little bit more through your stopper / ASIS osteotomy and lateral window?
Yeah, so thank you. So as I mentioned on my beginning of discussion, so we put the patient on traction table, and we did not want to disturb the fracture, or we did not want to open it extensively. So when we put the fracture and tried the closed reduction, it was reasonably okay. So we were able to put long PFN nail and with a helical blade, and then that was one thing that which helped us to manipulate the lower limb so that we'll be able to pull it and then apply some traction while we were able to while we were visualizing the acetabulum with a lateral iliofemoral approach, and then combined stopper approach. So that has helped us a lot. Fixing the lower limb first definitely helped to go for fixation of the acetabulum easily. Yeah.
That was a good technique. One other thing you could do is in that particular setting, if the patient is stable enough, you could just do, without fixing the the subtrochanteric fracture first, you could just kind of put a pin or something, and it's actually very easy because you don't have that femur, those forces acting, and you can pull it out. And as far as that posterior comminution, superior posterior comminution, a spring plate, as you've mentioned, if you were to go there, but you would have to go in the back for that, right? And so I'm just kind of curious, in terms of, if you have, acetabular, posterior wall, posterior column kind of comminution, and an interior kind of both column fracture, you guys go from the back first and then go in the front, or you guys fix in the front and then go in the back? Like, what would be the faculty thought process on that? Just for my education.
Hey, Rod, you've had your hand up for a while. Do you want to comment on that?
Sure. So whether I go front or back first depends very much on the nature of the fracture, and whether I worry that doing one part, the back first, is going to affect the front, or the front is going to affect the back, and which is going to have the most consequence. So when you have like transverse type fractures that have perhaps a posterior wall involvement, I'll go from the back first, and then I reconstruct the back, and then try to do either an anterior column screw or something along those lines. When there's fractures that have a lot of protrusio, that a significant amount of work needs to be done from the anterior column side, then we go from the front first and then address the back later on. So it varies. What I've gone away from doing is combined exposures that see everything. So I usually pick one or the other to go first. In this particular case, I think this is perfect. I think this was done very well. The only thing I would have added, because the patient's young, the patient's 19, correct? I would have perhaps thought of if there's anything I could do for the posterior wall impaction, because a young person, these posterior wall high impactions have a very high progression to post-traumatic arthritis that can be quite significant, particularly in someone who's only 19. And I don't think you were going to add much risk by trying to do something in the back, perhaps improve the concentricity of the posterior depression, resolve that impaction, and put a couple of screws and a spring plate. But ultimately, you treat the patient, not the X-ray. So if the patient has had enough surgery and it's fine, it's something you may want to accept.
There's a nice question in the chat about doing a stress test. I assume Dr. Teshome is asking about doing a stress test of the femoral head within the acetabulum to see if it was going out posteriorly with this posterior wall fracture. Dr. Milkias, is that something that you maybe stressed it intraoperatively to confirm that it was the reduction of the femoral acetabular joint was okay, and then you left it, or what did you think?
Yeah, that's a good point when there is an involvement of a posterior wall fracture. But we thought that we had a good fixation of the anterior column, and then we put a good screw posteriorly with for the posterior column fracture. And honestly, we did not test for the instability with that. We were cautious that there is a posterior fragment or fracture which probably would need fixation, but post-operatively looks like it was reasonably concentric. And then, but yeah, that's a good point. Probably that should have been done with a dynamic test for stability of the femoral head if there is any posterior subluxation or dislocation. But luckily, patient had a good concentric, reasonably concentric head. So, but we did not do the test. But I think that is a good point that should have been done intraoperatively with a fluoroscopic dynamic instability test. Yeah, thank you.
No, thank you. Dr. Mapuor and Dr. Brian Madison have both had their hands up for a while. Dr. Mapuor, would you like to go first?
Yes, thank you, Mike. That was a very nice case. My question is, as you have gone anteriorly to fix the pelvic ring plus the anterior column by putting a screw, would you have been able to put imperfect nail plate instead of that screw from the anterior? what is the take-home message from the audience or from the faculty member? Thank you.
Thank you, Mapuor. If you can explain your question again, infracalcaneal.
Yes. So what I want to say is, my question is, you have put there the screw from the posterior fixing the anterior column, right? And you have opened the pelvic from anterior, which is the stopper approach here.
Yeah.
Then was it possible to put the plate infrapectineal? Because this plate I see it is almost suprapectineal.
Yeah.
Would you have been able to put the plate infrapectineal instead of that screw of the anterior column?
Okay, so you were thinking to kind of avoid the lateral window so that addressing only with a fan and stem or with a modified stopper with infrapectineal.
Yes.
Okay. Yeah. So if you see the fracture or the fracture pattern of the injury, looks like the head has impacted the acetabulum from lateral towards the superomedial vector. So the fragments were, if we can see it on the 3D probably. Yeah, so to address the anterior column fragment and at the same time addressing the superior rami component, I think it would be reasonable enough to put a suprapectineal plate. Otherwise, I agree, probably adding an infrapectineal plate could probably add for the stability of the fixation. Otherwise, I would give priority for a suprapectineal plating since the vector of the injury is towards medial and superior. So otherwise, only adding an infrapectineal plate probably might not address the middle fragment and as well as the superior rami fragment, which we see it on the 3D. That's my point. I don't know if from the faculty, if anyone could add additional comments or points, I would be happy.
I think that makes a lot of sense, Dr. Milkias. Any other comments on that point?
Yeah. So if you would like to have infrapectineal plate when the main displacement is like medial. Here, the main displacement that you have is basically the the ischiopubic as well as the ischiopubic segment is basically hinging on the brim side, and then basically the rim on both the anterior as well as the posterior side of the rim is opened up. So if you try to put infrapectineal plate, it will not do the job. So it will actually open up both the rims on both the anterior as well as the posterior side. So in an ideal scenario, if you don't have a lot of things going on in this patient, putting suprapectineal plate, and then if you have the chance, you could, if you have if the patient is stable and stuff like that, you could avoid using the posterior column screw, and then you could potentially flip the patient and put a plate from the back in order to minimize the opening up from the back side. But in this specific patient, I think the issue is not really stability. Tashoma mentioned about stability test here. It is really the fracture has opened up from the posterior side a little bit, but is that clinically significant? Maybe not. The patient might just do fine as long as you see the concentricity well here. And I don't think it is going to affect it. But if there is anything you would do, you try to bring the hinge out and then put a peripheral sort of posterior wall rim plate on the posterior side instead of infrapectineal plate.
The one question I had was why not extend the plate across the pubic symphysis just to back up the posterior fixation? Is that something that you considered?
Extend across the symphysis?
Yeah, across the pubic symphysis, like plate across the symphysis, just to back up your posterior ring fixation. Granted, I'm not a pelvic surgeon, so I don't really know, but I'd be interested to hear your point on that.
Yeah, so thank you for the question. I think the symphysis was reasonably intact. So I don't know if we have two robust screws anchoring on the distal part of the rami fragment. I couldn't sort out any reason that we have to span the symphysis unless we suspect that there is a symphysial disruption. Otherwise, if we suspect any symphysial disruption, you are right that we just have to use a longer plate and then put a couple of screws on the left side of the superior rami. Otherwise, we did not suspect any symphysial disruption, so we thought that we have put two reasonably good lengths of screws on the superior rami, so that's why we did not consider spanning the symphysis.
I think that makes sense. Actually, now seeing the preoperative ones, I can understand your point that the symphysis was not widened at all, and the fracture pattern was such that the force was through that acetabulum fracture. So that makes a lot of sense. I think Dr. Brian Madison had his hand up a little earlier. Brian, did you have a point that you wanted to make?
Yeah. Thanks for the presentation. That's a lot of work to do, and you did a good job. I just have a question to you about the weight-bearing status of this patient. When will you allow them to put on weight on that limb? And also another question is, what's your experience about retrograde screw fixation for the acetabulum fracture? They go through from around the symphysis pubis and then you go retrograde. What's your experience about that fixation method?
Okay, thank you for the question. So regarding the weight-bearing status, definitely I would delay weight-bearing for about 10 to 12 weeks. So probably I'll make the patient non-weight-bearing for 6 weeks, since there is a combined fracture of the complete unstable pelvic injury, acetabular fracture, thoracochondric fracture, and then femur shaft fracture. So I would put the patient in non-weight bearing for about 10 to 12 weeks. And probably I might start after 6 weeks to touch weight bearing if the patient is able to do so. Otherwise, in such quite complex fractures, I would just encourage the patient to have passive or active range of motion of the hip and the knee, and then I would delay the weight bearing. And regarding retrograde rami screw insertion, that is a good technique for non-comminuted anterior column or non-comminuted anterior superior rami fractures that needs fixation. So that's a good technique, but we have to be quite cautious about the neurovascular that we could injure on the psoas gutter around all the neurovasculatures are at risk while we are putting our retrograde screws. That we need to have good views intraoperatively with a fluoroscopy. Inlet view has to be there. That we have to be sure the screw is not going either anteriorly or posteriorly. And then the iliac oblique view probably would help us avoiding whether the screw is not going superiorly or inferiorly, or it's not also in the joint. So the inlet views and then the outlet view and obturator outlet view will be helpful to avoid screw going from posterior and anterior, superior and inferior, and to avoid also the screw from going into the joint. So these views has to be quite visualized. And the other technique probably would be using a smaller screw 3.5 that we can drill only on the entry side, and then if we have a good orientation and direction of the 3.5 screw, probably we can drive it, and it would lead itself through the bone a pathway, and probably it could have a reasonably good stability, especially for superior rami fractures. Otherwise, for transverse acetabular fractures, which has to be used with retrograde nailing or retrograde screw insertion, we need to have a good visualization with fluoroscopy, which I have already mentioned. So this is my view. If the faculty can add points, I would be also very happy. Thank you.
Thank you all so much. Such great cases and really good discussion. I think we probably have time for maybe last comments from the faculty or any other questions here before we wrap it up here.
Yeah, I'll just kind of finish up to kind of thank everybody for a great talk. And I think Sami and Mapuor will agree with me. If you're doing pelvic surgery in a low income setting, and I usually say this on those grand rounds or those talks, you have to have, for example, in this case, you have to have good referral, somebody who understands the pathways, and like he showed a fantastic case for the third one. But the second case, there wasn't fluoro or there wasn't, imaging. So you have to be very cognitive of in what setting you are in and what your limitations are. And I usually say that because if you're gonna do pelvic surgery in a low income setting, regardless of where you are in the world, you gotta have at least the minimal tools or views to make sure that those cases end up quite well. Otherwise, it's gonna be that was just my comment in terms of you know your settings and know your limitations on that. That's just a caution for measures.
Yes, I just wanted to point out that, the excellent outcome of these cases kind of hides the fact that the most dramatic difference often between places like the United States and other nations with low resource conditions is the timing to surgery, right? Like here in America, we never get a pelvic fracture that's 2 weeks old. And we lose track of how hard it is to actually do a proper reduction and treatment on a patient that has been unmanaged for 2 weeks with a significant deformity. It takes a tremendous amount of skill and thinking ahead of time, and the steps you're going to do and how you're going to, at times, even osteotomize things to bring things together, or gently apply corrective tractions when, if you get a pelvic fracture that's in shear and it's been in shear for 2 weeks, how do you even bring that down acutely? It's just not possible. You have to put them in traction and monitor these things. So many surgeons in places like where I work have no experience in dealing with the cold pelvic fracture and how exceedingly difficult it is, and you guys make it look easy, and it's not easy at all. And I have a strong appreciation for that particular aspect of dealing with leg trauma. And I wanted to just commend you in your work.
I think that's probably a great comment to wrap up today's session. Really excellent cases. Thank you everyone for contributing. And we've been compiling some of the questions as well. So if yours wasn't addressed, we're hopefully going to look through and kind of organize some of the questions that came up in the chat today. And looking forward to seeing everyone next week. We're going to be talking about acetabular fractures. Kieran, did you have any last words?
No, I mean, I think you guys wrapped up the session nicely. Thank you so much for everybody, over 120 people who have stayed on the call for an additional 30 minutes to learn from all these tremendously talented surgeons who presented cases and also provided their commentary. Thank you so much. It means a lot to all of us that you guys participate in these sessions. So thank you very much. We'll all hang on the call a little bit longer in case there are any lingering questions, but we'll stop the recording there and wish everybody a wonderful day. Thank you so much for joining us today.
Thank you. Thank you.